Hello and welcome to Sureena Speaks, and today we're going to go over the itty little bitty bits of sections that are outside of the BNF but I think are really important for you to know for the exam and for practice in general when you do become a pharmacist. So they include, for example, advanced services, the laws that are regard to drinking and how they've changed. We'll also look at what medicines are teratogenic in pregnancy, and there's a nice little mnemonic to help us remember that. We will also go over reclassifications of drugs, so what's changed from POM to P, for example. So if we start off with our services, so there's three main types of services that a pharmacy can provide. They are essential services, like our repeat dispensing, signposting, advanced services, like our medicine use reviews, new medicine services, appliance use reviews, and our enhanced services, for example, smoking cessation. But we're going to focus on the advanced services, so our MURs and our new medicine services, because these are two really big services that community pharmacies in particular do provide. Now, not just anyone can be eligible for an MUR or an NMS, they need to fall into certain categories. So let's start off with our new medicine services. So, for example, if a patient has been started on a new type 2 diabetic medication like metformin or glycoside, they would be eligible, as with someone starting a new medicine for their blood pressure, for their hypertension, so amlodipine, ramipril. A patient that's taking a new medicine for their asthma or COPD, so we could have salbutamol or tiotropium, and a patient that's taking a new medicine or either a new anticoagulant like warfarin or an antiplatelet such as clopidogrel. So typically how new medicine services work is that you identify the patient is taking this medicine for the first time, and they have to sign a consent form, and after 7 to 14 days you would then either ring them or they might come back into the pharmacy and you'd have a short discussion on how they're taking the medicine. Are they compliant with the medicine? Are they experiencing any side effects? Do they have any queries? And then again, in another 7 to 14 days, you would do the same thing. And it's really important to identify if a patient is compliant with their medicine, if they are taking it in the correct way, and if they do have any questions. Now, you might have a patient that's on ramipril, for example, and after that initial 7 to 14 days, when you ring them up, ask them how they're doing, they might say, yeah, everything's fine, but I've started to get this dry cough. So then you need to remember, okay, ramipril, dry cough. Okay, maybe it's best they're referred, and then their prescriber can change them onto a different hypertension medicine. Or they could be on metformin, starting on metformin, and after that initial 7 to 14 days, they say, actually, I'm getting loads of GI side effects with this metformin. So it's really important to remind patients of what common side effects are associated with particular medicines. And typically with metformin, especially when a person starts taking it, majority of patients will experience some form of GI side effects. So this should go after a while. So it might be worth saying to the patient that, just hang in there, basically, obviously in a nicer way. But then after maybe that second consultation, when you ring them up, or if they come in after that second set of 7 to 14 days, if they're still like, you know what, these GI side effects are unbearable, then maybe it's best if they are referred. But actually, majority of the time, you'll find that by then the GI side effects would have settled down and they'll be taking their metformin fine. So that's new medicine services. Now let's go on to MURs. So with MURs, your patient you have to have been providing pharmaceutical services to that patient for at least 3 months in order for them to be eligible for an MUR. So it can't just be someone that you met yesterday that's on loads of medicines and you think, hey, great, yeah, let's do an MUR on you. It has to be someone that you've either been giving repeat dispensing for, or prescriptions for, or some form of pharmaceutical service in the last 3 months. So again, only certain patients who fall into certain categories are eligible for an MUR. So this includes patients that have been recently discharged from hospital, those that are taking medicines for respiratory disease, those that are on lots of medicines, patients that are on medicines for cardiovascular disease and they're on at least 4 regular medicines, or patients that are on 1 high-risk medicine. So you could have a patient, so what comes under high risk? So for example, an NSAID, so your diclofenac, naproxen, also diuretics come under high risk medicines, so furosemide, benzoyl, even potassium sparing diuretics like miloride. A patient that's on an anticoagulant or an antiplatelet, that counts as a high-risk medicine as well. So you might have someone come in and you've been providing them with naproxen for the last 4 months because they're on it regularly. So that counts as a high-risk medicine. So even though they're just on the one medicine, it would be best to do an MUR check on them. Why is that? Well, as we mentioned, it's high risk. You want to check that they're not getting any form of ulcer, GI bleeding, especially if they're not taking something like omeprazole along with it to protect their stomach. You want to check that they're taking it after food, if everything is okay. So MURs are really, really important in identifying that your patients know exactly what medicines they're meant to be on, what time they're supposed to be taking it. If it's levothyroxine, for example, they need to be taking it at least half an hour before food. So it's a great opportunity for you to counsel your patients, to educate your patients so that they are taking their medicines in the correct way. So an example could be that a patient is on a clenomodulite inhaler and they're not rinsing their mouth out properly after using their inhaler. Maybe they haven't been counselled on that. And so then when you explain to them that, oh, if you don't rinse your mouth out, you're more at risk of getting oral thrush, for example. And then they might say, actually, oh yeah, I've got these white deposits in my mouth, maybe that's what that is. So it's a great way to identify actually if a patient is experiencing some form of side effect. And you'd be surprised how many patients are actually very grateful for you for taking out a bit of time to go through their medication and to check that they do understand them. And particularly in community pharmacy, it's nice because you get to build that strong rapport up and relationship with your patients through MURs. So it's a great service to provide, and it's just nice to know that you're helping people in doing so. So in terms of alcohol and the law, so if you do some older past papers, the answer to questions might be that men can have 21 units of alcohol, women can have 14 units of alcohol. But that's all changed now. I think it only changed actually last year. But now what the law states is that both men and women should only have up to 14 units of alcohol a week. Now that doesn't mean that all 14 units should be consumed on a Saturday night out. Those 14 units should be spread on at least 3 or more days, and you should have several drink-free days. So they might want to ask you questions based on how many units of alcohol are in different alcoholic drinks and to compare them. So 1 pub measure spirit is 1 unit. A pint of lower strength lager or cider is 2 units. A pint of higher strength lager or cider is 3 units. And a glass, 175ml glass of wine is usually 2.1 units. So because it is a recent change that has been made, it might be something that they want to ask a question on. So let's focus now on teratogenic medicines in pregnancy. So now there are lots, but let's just try and remember a few of them, and we can do so with the mnemonic Teratogenic or Teratowa. So T stands for thalidomide. E stands for epileptic medication. R stands for retinoids such as vitamin A. A stands for ACE inhibitors and angiotensin II receptor antagonists. TERA. The other T stands for the third element, which is lithium. O stands for oral contraceptives and hormones. And then the W bit, the W stands for warfarin and the A for alcohol. There is also tetracyclines, methotrexate, antithyroid medication. So remember as many as you can, but those are the key. The isotretinoin is another example, but those are the key teratogenic drugs in pregnancy. It's also good to remember some examples of enzyme inducers and enzyme inhibitors, because again, that's something that they like to ask. So examples of enzyme inducers are, for example, rifampicin and St. John's wort. Examples of inhibitors are metronidazole, fluconazole, and I think a good way of remembering enzyme inducers and inhibitors and what effect they have is actually using warfarin as an example. So if we think of warfarin, we think of INR. INR, the way that I remember it, and it's just my way of remembering, is I think of INR as runniness. So if you have an increase in INR, the blood's going to be really runny. If you have a decrease in INR, the blood is less runny, which means it's more clotified. Yes, we're using wonderful scientific language right now, but bear with me. So if we're using enzyme inhibitors, so our metronidazoles, simvastatin, the way that these work is these enhance the anticoagulant effect of warfarin. So they are, in essence, warfarin's buddies. And they're like, you know what, warfarin? We promote what you do. We like that you're an anticoagulant and that you make the blood runny. So we're going to stand by your side. And when we're taken with you, we are going to enhance that runniness. So what it does is it increases the INR. Whereas with your enzyme inducers, so your rifampicin, St. John's wort, what they do is they decrease the anticoagulant effect. So like warfarin, we don't agree with your runniness. So if you're taken with us, actually, we're going to decrease this anticoagulant effect. We're going to become more clotified. So that's what helped me remember which is which. Hopefully that'll help you remember that too. And yes, using very great scientific language there too. So now moving on to reclassification. So there's many different examples of medicines that have been changed from P to POM, POM to P, but we're just going to look at a select few. And if you want more details on any of these, they are all on the RPS website. I will include the link in the description box and on the Facebook page to have a look at that. So let's start off with Amorolfine nail lacquer. So that's used in fungal nail infections, and it can only be sold for over 18-year-olds, for patients who are over 18. However, there's a lot of cases when you can't give it. So, for example, if more than 3 nails are infected, if the patient is diabetic, immunocompromised, if they're pregnant or breastfeeding, they will all need to be referred. You can't give it in those situations. Moving on to azithromycin. Azithromycin's for chlamydia. Unless you have a PhD in place, it can only be given in over 16-year-olds. There is a national screening programme, though, available for under 25-year-olds. And the signs of infection usually take up to 2 weeks to be apparent. So only do the test 2 weeks after having intercourse. If you do the test straight after, the results will come back negative, and it's not true results. So they have to wait 2 weeks. With chloramphenicol, we can get it in drops and ointment, and this is for conjunctivitis. The drops should be used every 2 hours for the first 48 hours, and then every 4 hours after that. Ointment can be applied 3 to 4 times a day. You should be discarded after 5 days, and usually if the patient doesn't have any benefit after 5 days, then they should be referred. But actually, once you open the bottle, it has a shelf life of 28 days. In cases when you shouldn't give it is if the patient has a family history of blood dyscrasias. Moving on to orlistat, so we can give 60 milligrams. 120 milligrams is still prescription only. In my GI video, I actually go into more detail about orlistat to have a look at that. But in summary, we can give it to an over 18-year-old if they have a BMI of over 30 kilograms per meter squared, or if they have a BMI of over 28 kilograms per meter squared with risk factors. Now, if it's ineffective up to 12 weeks, they should be referred, and they shouldn't be taking it for more than 6 months. It's highly recommended that patients taking orlistat also take a fat-soluble vitamin such as A, K, E and D, because these don't get very well absorbed when a patient's taking orlistat. So in terms of tamsulosin, 400 micrograms, we can give this to male patients aged 45 to 75-year-olds only who have had symptoms of benign prostatic hyperplasia for a minimum of 3 months. So we'd give a 2-week supply initially. If they gain benefit, then we can give them a further 4-week supply. Now, in situations where we can't give tamsulosin, would be, for example, if the patient's had the symptoms for less than 3 months, if they have potential or unstable diabetes, or if they have any cardiac, renal, or hepatic problems, or if they've had prostate surgery, for example. With regards to sumatriptan, we can only give it to 18 to 65-year-olds. Situations where we can't give it, though, is if a patient has high blood pressure, if they're epileptic, if they're pregnant or breastfeeding, or if they're over 50 years old and this is their first migraine attack that they're experiencing. In these situations, we would need to refer. In terms of tranexamic acid, we can only give this to females over the age of 18 who have heavy menstrual bleeding with a regular 21 to 35 day cycle with no more than 3 days variability. So in other words, if a woman gets her period on January 1st, and then her next one is February 27th, and the next one is March 17th, this kind of patient wouldn't be eligible because they've had more than 3 days variability and then don't have a regular 21 to 35 day cycle. The dose that should be given is 2-3 times a day for a maximum of 4 days. We can't give it to patients who are on oral contraceptives, who are pregnant, on warfarin, and we would refer patients who are, for example, breastfeeding or have polycystic ovary syndrome or are diabetic. So in terms of omeprazole, we can give omeprazole 10 milligrams. The dose though would be 20 milligrams for 2 weeks. If after 2 weeks they've had no relief, then we refer them. So it's licensed for the short-term relief of heartburn and reflux-like symptoms, and we can give it in 18 or over 18-year-olds. In situations where we'd have to refer them would also be if they're 45 years old and this is the first time they're experiencing these types of symptoms. If they're over 55 years old with recent onset dyspepsia that's not responded to any other treatment. And if they're patients who have had previous GI bleeding, ulcers, jaundice, and also heartburn sufferers who are pregnant or breastfeeding. So just some other general pieces of advice. Know your paracetamol and ibuprofen doses for children, because that's something that I want you to know off the top of your head, and it's something that they could potentially put in the maths paper. In terms of the maths paper, the biggest piece of advice I could give is practice, practice, practice. Get your hands on whatever practice papers, past papers, question papers that you can. There's a book called MCQs in Pharmaceutical Calculations. Personally, I found that quite helpful. It is MCQ though, and I know the exam format has changed so that the exam isn't multiple choice questions for calculations, but don't put that off. Don't let that put you off. At the end of the day, the more questions that you can do, regardless of what format they're in, it will all be beneficial to you. Knowing in particular the different methods that you need to learn for particular calculation questions, that will greatly help you. Know your equations as well, like your Cockcroft and Gault equation. That's the main piece of advice I could give for that. With regards to over-the-counter side of things, again, if you can, if you're in an environment where you can, then go onto the healthcare desk and try and learn all the different over-the-counter products that there are. For those of you that maybe aren't in an environment where you can easily look at over-the-counter products, if you're in, for example, an industry placement or a hospital placement, then what I would say is look at the different PILs, look at what, for example, different head lice products that are available, which ones you could give to asthmatics, which ones aren't recommended. In other words, ones containing alcohol, just don't give to asthmatics. Look at different cough products available. Again, like I mentioned, your PILs. Look at the NHS websites, they're at your fingertips, and literally if you just write in any condition and then put NHS at the end of it, it will give you so much information in terms of the treatment, background knowledge on it, which will all really help. Also your SPCs, I know I've said it before, but make sure you know your SPCs, know your format of the SPCs, because if a question, you will undoubtedly get a question involving the use of an SPC. You'll probably get multiple questions involving the use of an SPC. So if you know that, okay, indications is going to be in this section, side effects is going to be in this section, they're all laid out in the exact same way. And if you familiarise yourself now with what that format is, when you're in the exam and they ask for a question on the contraindications or on the side effects or excipients, whatever it may be, you will know that, okay, this is the section that I need to look at in the SPC, and you won't be wasting time faffing around trying to look for the information. You'll know exactly where to go. And for these exams, the key thing is your timing. Also with exams, what I will say is I know at the moment there will be a lot of mock exams trying to lure you in. My personal advice is, and what I did was I went for the reputable companies that are out there, the more legitimate companies that are out there, because there will be a lot of mock days promoting themselves, and a lot of them are really, really expensive as well. So I just went for the ones that I thought were the most reputable. That's not to say that the ones that aren't as well known aren't good. They might be brilliant. I personally, I don't know, but I can only go off on my own experience and what I did. So I just went for the ones that I'd heard of beforehand. And in all honesty, they were okay. I think the greatest benefit, though, that you get from these mock days is actually being able to sit down and do a mock paper in timed conditions. And it might be that you feel like you know nothing and you might get more questions wrong than right. But actually, at this point, get those questions wrong, because you will learn from those wrong answers that you get, and it'll at least highlight to you which areas it is that you need to sharpen your knowledge on. Now, it might be that you feel like, okay, I need to sharpen my knowledge on everything, because right now I just don't know anything. But you will be surprised how much you do know. So have faith in that. And yeah, just practice. Just keep practicing those question papers. Because a lot of the time, what I found was I knew the knowledge was there. It was actually applying it, which I found harder. And because these questions aren't just, name a side effect and metformin. It's more, here's a case scenario, and then there's questions based on that case scenario. And I think until you do questions, or at least try and practice a few questions, then you'll get more of a feel of what the exam is expecting of you. So those are my key pointers. If I think of any more, I will most certainly put them on the Facebook page. And I hope you found this video useful. And if you did, give us a like, give us a thumbs up, share, subscribe, join our Facebook page for all the latest information and for any extras that I put up there for your help and your benefit. And until next time, good luck with your revision and happy revisings.